First of all, I'd like to say thank you to the Transverse Myelitis Society in the United Kingdom for inviting me to this symposium and to talk about the subject about rehabilitation in terms of how I approach things, or I won't pretend to speak for the entire population of the United States in terms of physicians over there, but how a lot of us who see a lot of patients with transverse myelitis and related conditions, how we approach things. I don't really have very many disclosures. I was formally funded by the Transverse Myelitis Association for my fellowship, so obviously that biases me, but in a good way. And I have no industry disclosures to report. I'm from Cincinnati, so some of you may be thinking, where is Cincinnati? It's in Ohio. It's in Ohio, in the southernmost portion of Ohio. Some people refer to it as the Birmingham, UK of the US, but I actually just made it up for this talk. So when I first see a patient with transverse myelitis, I'm going to take us to the first clinic visit, which is usually after the first event. And I really review with them what happened during the first event. I go over the time from the onset to the nadir, so when the symptoms started to how bad they got or how quickly they got to the worst they got, their imaging characteristics, what their whole complex of symptoms entailed, and usually I see transverse myelitis patients, or I recommend that they are seen within a few weeks or a month or so after they're discharged, after they're done with their inpatient rehabilitation stint if they required it, because in a few rare cases we've entertained the possibility of doing more acute therapy. And the other issue is if they're a chronic patient or if they've had it for a long time, what other things can we do to help optimize recovery? To go back to what is transverse myelitis, this is the working group definition from 2002, popularized by Dr. Kerr, that really speaks to how we diagnose it. There is no, as I call, yes/no test in the United States, meaning no spinal fluid test or no blood test. That if it's positive, definitely means you had transverse myelitis, and if it's negative, definitely does not. So there's no yes/no test, and so it's a clinical diagnosis. The reason for imaging very quickly for transverse myelitis patients really speaks to the ruling out cord compression. A lot of the blood tests and the spinal fluid tests that we're doing are ruling out or attempting to rule out certain causes of transverse myelitis and trying to determine if it is a one-time event or if it's a syndrome of a recurrent process, such as MS or NMO. And there's a small subset of TM patients that have recurrence of TM. I put this slide in here because I always like to remind myself, as well as when I go through things with patients. This is a cross-section. This is a drawing or with a cartoon of the spinal cord, and this is some axial cross-sections. As you descend down the cord, you'll see that in the center part of the cord is the gray matter of the cord, that the gray matter of the cord comprises a lot more in terms of percentage of the overall cord as you go down it. And the gray matter contains a lot of the neuronal cell bodies. And so the problem is when you have a lot of gray matter impact from your TM episode, the neurons are lost, and that's a little bit different than axonal loss. And sometimes it kind of impacts how we look at things for certain patients. And in terms of the thoughts regarding diagnosis, there's always some of these patients that are initially told they have transverse myelitis, although this is very difficult to prove. There's some of the concern is if they had a very fast onset, that they may have had a vascular myelopathy. And there's different, now in truth from rehabilitation standpoint, a lot of the same principles really do apply, whether it was a vascular or an inflammatory cause. But it may approach how we look at things moving forward. If there's a lot of gray matter of the cord involvement, they have what I call neuronal loss and less myelin loss. And if they have more white matter of the cord involvement, then it's thought to be more myelin loss. I'm going to talk about this very briefly because Dr. Young did such an outstanding job. There is an intertwinement of all of this. in terms of the physical function of the individual. And when I mean physical function, I don't just mean the strength, but I also mean sensory, bladder, bowel, etc. But all of these other symptoms impact it in various ways for different people. And that's really in terms of what rehabilitation aims to optimize is your physical functioning, but oftentimes we have to focus on fatigue for some individuals, pain for others, and other issues for other people. It's a vicious cycle. It is so if you're weak or if you have baseline weakness, your tasks require more time. You're allotting less time for sleep, less time for physical or occupational therapy for stuff you should be doing at home as instructed by your therapist. And then you have impact of other symptoms, bladder and bowel, etc. And then you find yourself in kind of a cycle and say, I can't be where I want to be. Physically, I feel like I was in a good place when I exited my inpatient rehabilitation facility, or for the first few weeks after inpatient rehabilitation, or after rehabilitation when I first got the event, and I feel like I've just taken a constant step back and I can't get back to there. And that's where this cycle comes in. This is just another slide, just kind of looking at how I try to look at sleep and fatigue and pain and bladder bowel. I really do focus a lot if a person comes in and they're having a lot of issues with fatigue and pain. Sleep is actually one of the first things I focus on, just because if you're not sleeping well, you're not going to function well. And trying to get at the root cause of what is interrupting your sleep, whether it's bladder bowel dysfunction, the spasticity and pain, whether you do or do not need a sleep aid, bed structure design. So there are certain patients that have issues with being able to turn themselves, if they have a lot of core muscle weakness, or if they have a lot of difficulty transferring themselves, then getting in a good position in their bed is difficult. Sometimes that's difficult for us to achieve, but getting basically a hospital, a bed that could be used in a hospital in terms of a specific type of mattress can sometimes provide a world of relief for patients. And I'm very quick to order, or I don't know how difficult that is over here, but order to get a patient into a sleep study if I feel like I've looked at several of these things and they tell me that they're not sleeping well, or they're super exhausted and do not feel rested in the morning. Because if you're already not feeling rested in the morning, then you're going to have a tough time navigating your day. Sleep should be your investment. And so in terms of if you look at your energy level as a certain amount of money that you have in a day, sleep should be your big time deposit at night, and of which you draw off during the day as you use up your energy for certain tasks. But stepping away from that, multiple of these other issues are definitely very important. In terms of fatigue, medications as stimulants like Adderall, Vyvanse, I'm using the trade name, dexmedemphetamine, and certain medications like modafinil, which is also called Provigil. Sometimes in certain patients, they can provide a world of difference. I want to talk about a medication, and I'm not sure how widely available it is in the UK, called 4-aminopyridine. It's also referred to as fampridine or dalfampridine. And in the MS world, the trade name for it is called Impera. It's a potassium channel blocker, and what it does is it facilitates faster nerve signal transmission across demyelinated axons or demyelinated segments of nerves. It may improve, in certain select patients, it may improve movement, endurance, in certain patients, sensory symptoms, fatigue, and bladder bowel dysfunction. How does it work? So when you have any kind of problem where you lost myelin, which insulates the axons of the nerves and facilitates faster nerve conduction, like the insulation of the wires of your house allow the electricity to conduct more quickly. When you lose myelin, the electrical charge is driven by positively charged sodium ions. But when you have myelin loss, the body naturally inserts potassium channels along those bare segments. The potassium channels leak out positively charged potassium, and that offsets the charge. And so what the medication does is a potassium channel blocker. It blocks the loss of potassium ions across in demyelinated segments, and theoretically you should have faster nerve conduction. What it does not do in this medication was initially studied in MS patients, and they call it the walking medication just because that's what they studied in MS patients. It does not actually heal nerves or remyelinate them. It may not be universally effective. About 40 to 60% will be what they call responders to the medication. And the reason why I mention this is this one of the few medications that can help restore some degree of function to certain individuals. And for certain people, it's very minimal. And for certain people, it can be quite significant. Some people report a significant improvement in their overall energy level or endurance. And for certain individuals, that can be really life-changing. And so that's why I talk to TM patients. In terms of, some people say, well, do you have trouble getting it? And sometimes we do. It can be found, the generic form of it is 4-aminopyridine, and we have pharmacies that have to, what they call, compound it. And they have to compound it into pill form. And for certain patients, it's out of pocket. Sometimes we usually can cost around $50 a month. I don't know what that would translate to in terms of pounds. In terms of the rehabilitation in the United States, one of the most important modalities is what they call functional electrical stimulation, which is popularized most by what is considered at least the best facility in the United States called KKI, or Kennedy Krieger Institute. And they are huge proponents of this, and I've seen very outstanding results from them, and they've published a lot of papers. There are a lot of other centers that do some form of this in the United States, maybe not to the degree that KKI, which is affiliated with Johns Hopkins University in Baltimore, does, but there's a lot of people that do some offshoot of this. There's handheld units that people can get that they can work with their, what they call physical medicine rehab doctor in the United States. I think it's what you're referring to as the neurophysiotherapists and the physical therapists in the United States, and where they have handheld units and they can attach the electrodes to the muscle groups that they're trying to exercise, and it provides co-stimulation with what they call activity-based therapy to combine the functional electrical stimulation with the exercises that they are instructed to do. It can be quite effective. I just took these couple of papers, these are more recent papers, as examples of how well studied it is, and it bears a lot of support. The reason why I think it's so important is really, I think, emphasized in this statement popularized by Donald Hebb in the late 40s, said neurons that fire together work together. And it's really all about getting what they call the central pattern generator going in the spinal cord, a sort of automatic driver of walking to help to drive the walking ability. The full-on functional electrical stimulation, where they have extraordinarily expensive equipment, if you were ever to visit KKI or if you know anybody who's been there, they have these very expensive equipments, is very resource intensive and requires a certain amount of dedication and aggressive care. But they have found that, at least in selected patients, is working with the handheld units, which oftentimes can be procured for most of the patients, and working on an exercise regimen for as little as 3-4 hours a week can, in some patients, sustain some improvements that they've had in the intense rehabilitation experience. The benefits of any kind of this, what they call functional electrical stimulation, activity-based therapy that's used in conjunction with it, and the benefits of exercise is really multifold. Reducing the risk for muscle atrophy, reducing risk for osteopenia or bone loss, better cardiovascular health, reduction in fatigue, improvement in mood and depression. And also, I want to think about, because there are remyelinating or regenerative therapies in the pipeline right now or in early clinical trials, I want people to remember that the people that are probably going to be the best candidates for seeing benefits from those medications are going to be the individuals that really are sustaining as best as they can. And I can only imagine it is an extraordinary challenge for many of you and for many of the families. But really the ones that are going to see a lot of the benefits with these regenerative therapies, or the responders, are going to be the ones that really are able to sustain their rehabilitation. I want to talk about this, and this is a nerve transfer. I don't know if anybody has ever heard of this. This is something I am very quick to, in certain select patients, refer patients for. And this is usually in the first year or so after the transverse myelitis event. It's not a novel concept. It was initially explored in 1912. Basically, the idea was, can we use unnecessary or less necessary is probably the better word, peripheral nerve allografts from yourself to help restore function. And I'd like to first add, I'm not a surgeon, so I don't do these procedures, but I've worked closely with several surgeons who have. There's a couple papers, and these are just case reports, where a child that had TM had some restoration upper extremity motor function with a nerve transfer procedure. This group, which is based out of New York, has been trying to explore this strategy more aggressively, and this is actually a very good paper. When I go, and I'm going back to this classification scheme for transverse myelitis when I talk about the white matter and the gray matter, and then they had the central cord syndrome and the anterior cord. A lot of these patients that we feel that I've seen that seem to be responders to the nerve transfer are the patients that have cord involvement, but then they have what they call their root or their nerve roots as they're exiting the spinal cord involvement. It's sort of a variant on TM that exploded in the United States this past year. I don't know if any of you have heard of this infection-related myelitis, but it's been happening. There's a few cases of this every year, and there was just more this past year than other years. But these patients that have root involvement, and usually this is exemplified by the fact that in their affected limb, that their weakness is they still have a lot of flaccidity, or a lot of their limb is loose. And a lot of those patients actually had root involvement in addition to cord involvement. The benefits in terms of obstacles to this procedure, I'm just looking on time, not too bad. Peripheral nerves, the theory is peripheral nerves have a greater regenerative capacity than the central nervous system. It's an adaptable procedure, so theoretically, various individuals with certain types of lesions, etc., it can be adapted to their needs. Because you're using your own nerves that are transferred, there's no immune-mediated rejection concerns. The obstacles is when you're using the peripheral nerve, root implantation versus actually implanting it in the spinal cord. The latter is A, controversial, and B, still in sort of pre-clinical assessment. That group in New York, for example, had another paper that they were exploring techniques in cadavers, trying to see if it's optimal. There are some case series of nerve transfer where it was done from a nerve to a root, bypassing the lesion in the cord, and with some with a little bit of success, but other papers with very little success. The issue is you have to get the axons to grow in some situations a long distance to the target muscle, and axonal growth is extremely slow. And so the theory behind the nerve graft is you're trying to get an intact nerve to basically be in contact with an area where there are motor neurons to tell it to stimulate, hey, we need to get you to grow. Whereas in a situation where otherwise it wouldn't be wanting to grow or desirable to grow or desiring to grow. And of course, there's a limitation of usable substrate. You're limited by how many nerves you can transfer in an individual. Who is a candidate? So patients with cord plus proximal root involvement. Theoretically, patients with isolated cord involvement with either gray matter or what they call anterior horn involvement may be candidates in the future. And there's a couple papers that try to explore this option acutely. But there are a couple centers that are looking at this in the future for patients that had a more remote injury. And is this going to be a viable technique? And I think that moving forward, when you talk about things like 3D printing, which seems like almost science fiction, but that might actually open up an avenue for expanding this option. Now moving forward, I'm going to talk a little bit more about science, a little bit more of moving forward in terms of what we can expect in the future in terms of it almost seems like science fiction for some individuals in our field. You know, we're at a point in medicine where our basic science medicine is very sophisticated, but our therapies really lag behind in specificity if you think about it. Things like steroids, plasma exchange, IVIG have multiple and very complex effects on the immune system. And they're really not very targeted therapies. Now, there are targeted therapies, or like, for example, in MS has a couple of very targeted therapies, but in our acute therapies are very non-targeted. Even proven effective therapies, functional electrical stimulation is working on multiple mechanisms, although it's a very simple theory. By what you can look at all the papers in terms of what the growth factors it's causing improvement of, and they talk about axonal density and all these very complex things. It's having multiple effects, and so we are not in an area where we have very targeted therapies. And stem cells, and there are a few centers in the United States, because a lot of people ask about stem cells, that are in some early clinical trials for stem cells. But we have to realize that why people are using stem cells is we're relying on the ability of the cells to, quote, know what to do, which translates really into, it's been so hard to identify targeted agents to facilitate recovery, so let's let the wonders of the intrinsic mechanisms of the body do the work for us. And that's the theory behind stem cell therapies. I'm not saying they're not going to be successful, and I'm the first person to say, if there's have proven success, then I want to sign people up. But when people are saying that really they're exploring that, is they're really trying to induce a positive regenerative capacity within the individual's own body, because that's how hard it is. That's how difficult it is. I don't know if anyone's heard this term called trophic. So there's a lot of concern about what is trophic for the spinal cord. Trophic means the definition promoting cellular growth, differentiation, and/or survival. And so there's a lot of emphasis now, and there's in early clinical trials, there's a couple medications that are somewhat promising. So I don't know if anyone has ever heard of anti-LINGO-1 antibody. It's focusing myelin repair. LINGO is something that shuts down myelin repair. So LINGO is shutting down something that's shutting it down. So theoretically allowing myelin repair. That's, I believe, now in phase 2 clinical trials. Alexozine. I don't know if I'm pronouncing it correctly, actually. I barely know English. This is also focusing on myelin repair and is either finishing or just past phase 1. RIG M22, this is out of Mayo. This is also focused on myelin repair. And then there are a couple other a little bit more out there things. If you look on the clinical trials website for the United States, there's a medication called clemastine fumarates. Haven't really been too familiar with that. Riluzole is a medication that was used for ALS with very limited success, being thought to be maybe it's neuroprotective for spinal cord injury, for patients with medical spinal cord events. A medication called minocycline. It's some people think it can be neuroprotective. There's these 3 medications that are very well known to neurologists: quetiapine, valproic acid, and benztropine, that in a couple of studies claim to promote myelination or remyelination in an animal model. And so I don't know what the likelihood of those having success with humans. You talk about in the academic world in the United States, they want something bench to bedside, and what does that mean? It's emphasis on what they call translational research. And the reason why I'm including these 2 slides is I just want to get a sense. I just want to let people know that there is work being done, and because a lot of people they're so frustrated. They're like, I hear about this, and then all of a sudden I don't hear about it anymore. Like, where is it? Like, are there studies or what's going on with it? And I just like to mention kind of what's going on with these things, just because, so people have an idea of the process. There's a theoretical benefit and discovery process, the proof of concept, and then there's the safety dosing. All this is the clinical. So that seems like, oh, that's not too complex. But then if you look at, this is just one slide from one company, one group, about the discovery phase and all that needs to be done in the preclinical phase to guarantee, quote, safety, to guarantee that it's doing what we think it's going to do without significant toxicity and all these things. And so there are people working very hard, and I think that we are at a junction with patients that have had a transverse myelitis event, where with the couple of the medications I mentioned in the earlier slide that are clinical trial phase, that I think we are going to see some regenerative therapies in the next, I would say, 4 to 8 years that are really going to provide some benefit for a certain subset of TM patients. Finally, I would like to thank, so that you can, if you are dissatisfied with this lecture, I hope not, but if you think I'm also a little bit crazy, you can blame these 3 individuals who were responsible for most of my training during my neuroimmunology training, Dr. Elliot Froman, Ben Greenberg, and Dr. Donna Graves, who are all at the University of Texas Southwestern and helped train me. Dr. Donna Graves is in Charlotte currently now. I also like to thank, most importantly, Sandy Siegel and the TMA for providing me the opportunity to work with transverse myelitis patients, providing, this is Sandy, I don't know if any of you have ever met him, and also the opportunity to advance my training. And I'd also like to thank, again, the Transverse Myelitis Society here for giving me the opportunity to talk about some of our approaches in the United States, some of what I'm thinking of and we're hoping to achieve moving forward, and what I hope are avenues for improvement for patients in the future. Thank you.